Okay. So hello everyone. It's going to be a tight circle for this online session of the Early Career Psychiatrist Committee of the Russian Society of Psychiatrists. My name is Andrei Kibitov. I'm a psychiatrist and I'm chair of the International Relationship section of ECP committee. And I'd like to introduce our colleague from Spain, Dr. Joaquín Galvañ. I'm terribly sorry if I mispronounce your name.
It's okay.
Dr. Galvan present his work about working in psychiatry, about collaborative research in Spain, collaborative research on psychosis and related topics. Okay, thank you very much, Dr. Galvan, for your participation, for your connection with our committee, and here.
Okay. Well, first of all, thank you for having me here. It's a pleasure to me. Thank you for Aliona who has invited me to join you for this event. I met her last summer when she came to my hospital in Madrid for a little stay, a couple of weeks, and yeah, she proposed me to do that, and I'm glad to be here with you, and hope you will enjoy the session. Thank you, Andrew, for introducing me, and you have pronounced my name perfectly, so no worries. Yeah, as I work in research, I decided to organize this little session as a scientific paper. So we will go across this 5 points. Background. I will talk about my personal background and the background of the research group where I currently work. Methods. I will talk about the way we do research in the group and the different projects we made in which I'm involved the most. I will speak of them in which I'm involved the most. Then a little bit of results. I'm talking about some recent papers that have been published in the past months related to this project. In discussion, I will talk more about my personal project of research. Will be a project for my PhD, and yeah, finally a little conclusions. Okay, to end this session. So, starting by the background. Well, my personal background, I don't know how it is in your country in Russia, but honestly, I always find interesting to know how doctors do their trainees around the world. So probably it will be a little bit different, probably not. But yeah, I want to get this opportunity to talk a little bit how we do our trainee here in Spain. We have to do 6 years at medical school at university. After that, we have to do a year of preparation for a national competitive examination to choose a specialty. It means that we all do the same exam, and depends on the scores we choose one specialty or another. It was like the one who get the highest scores can choose the first one, so he can choose whatever specialty in wherever city, in wherever hospital, all around the country. And the second one can choose whatever specialty in wherever hospital, but the one that has been chosen but the first one. So this is the system here to become a specialty. I don't know how it is in Russia, and maybe it's the same, maybe not. And after that, we have to do 4 years of specialized medical training. I've made 4 years because when I did it was 4 years, but now a couple of years ago it changed for 5 years. So finally to become a qualified psychiatry, you have to do like now 5 years for the training for psychiatry, plus a year for the exam, plus 6 years at medical school. It takes like 11 years to become a psychiatrist here in Spain. After that, you can do a master's degree. I do mine in bioethics. And then you can do a PhD. That's what I'm doing right now. So I chose, well, after did my exam, I chose this hospital to do my psychiatry trainee. It's in Mallorca. It's an island in the Mediterranean Sea. I don't know if maybe you know it, because actually there was a lot of British friends in Germany, but also Russian people there. And it's a nice place to be. I spent there for 4 years of my life. This is the hospital where I made my training. And after that, for some reason, I left that paradise we can see, and I finally came to Madrid, where I live now. It's a big city, the capital of the country, the capital of Spain. And I spent 2 years doing clinical work, and just clinical work. And then after that 2 years of a mixed contract between clinics and research, and that's when I started to do some research in mental health. And yeah, finally, what I'm doing now is full-time research work. I'm doing it because I won a competitive national pre-doctoral fellowship. So you have to ask to the ministry, to the Spanish government for a grant to develop a project. You have to present a project and in competition with another one. And if you are the chosen one, you receive this grant to just dedicate full time into this project. My thesis project is called Clinical Predictors of Disease of Disease Progression After a First Episode of Psychosis. And yeah, the grant is not so much, so you can make much money as a medical doctor, but on the other hand, you have enough time to dedicate full time and doing research, and yeah, and to get better. The PhD, that is my main goal right now. Probably after that, I will back to clinics. I found interesting to tell you this because, again, I don't know how it works in Russia, if you have this kind of possibilities or not, so that you can compare a little bit the system there and here. And yeah, so now I'm doing full-time research with a grant from the Spanish government. This is the application you have to do to get this grant. It's in Spanish, but yeah, what I want you to know is that it's as important yourself as a candidate as the research group where you are going to develop the project. So if you have to score 100 points, 50% it's by your side, and the other 50% it depends on the research group you choose to develop the project. So it's as important yourself as a researcher as the group where you decide to develop your project. So I decided I chose this hospital, first of all, because it was the hospital where I was doing clinics before starting research, and because it's a great hospital in Madrid with a great research institute. I'm gonna talk about it, about the group of research in the next point. And it's not just me saying that. If you take a look at the Spanish ranking in the psychiatry, between the psychiatry department, we are number one, and in all general hospitals, this hospital is the third one. So it's a third best hospital in the country, and the best one in psychiatry. So I think it's a good place to work and to have the research. It's actually the place where Aliona come to do her stage during the summer. This is a little bit a chronology of the history of the service, starting like 25 years ago, and you can see how the service grow, and also in parallel of developing a lot of research projects. I'm going to talk about them a little bit the next point. And here you have like the European 6 priorities points for mental health research, in which is based the values and the objectives and the goals of our service. And I think it's interesting to talk about them in this session. First of all is to focus research into mental disorder prevention, mental health promotion, and intervention in children and adolescents. Focus also on development and causal mechanism of mental health syndromes and well-being across the lifespan. And developing and maintaining international and interdisciplinary research networks and share databases. I think that is very, very important to establish networks and share databases with other centers to help to develop the science. And yeah, of course, developing and implementing better intervention using scientific and technological advances. It talks a little bit about transnational research. I'm going to talk about this in a few minutes. And reducing stigma, I think this is very important work also. And yeah, of course, taking account of take account of socio-cultural and socioeconomics context and approaches. So that was like the priorities at a European level, and this is the mission, vision, and values of our research group. It's more or less the same thing. Okay, our group is an institution that aims to carry out the highest quality cooperative translational research. I think it's very important to the translational research for generation of knowledge and fast application of advances in care practice. So again, talking about translational research. And yeah, well, this is a little resume about the vision and values, ethics, leaderships, competitiveness, commitment, excellence, and innovation. And well, what does it mean translational medicine or translational, translational medicine or translational research? It means that we have to, for doing a good research, we have to look into the problems we found in clinical practice to trying to answer some questions that came from that part, and clinical practice must look for answers into research. So it means it's not just research for research or knowledge for knowledge. That's more philosophy. It's not bad, but for science, I think it's better to focus the research in the needs we have in clinical practice. So take a look at clinical practice and look for what we need to develop a better clinical practice, and starting research this way. And on the other hand, clinical practice, I think, must focus on looking for answers and on research, not just the experience on everyone or asking to a colleague. So yeah, I think translational medicine and translational research is very important, and keep connected the basic research with clinical practice. Well, this is our group leader, is Dr. Celso Arango. He's the director of the Institute of Psychiatry and Mental Health in the Hospital Gregório Maranьón. He has just named as member of the United States National Academy, and he was already a member of the Royal National Academy of Medicine of Spain. He's professor of psychiatry here in Madrid, but also in United States, in Maryland, California, and London also. And he has chaired the European College of Neuropsychopharmacology and the Society of Psychiatry and Mental Health. And this is your colleague Aliona with him during her stay here with us. Yeah, that was a little background about my training in psychiatry and about the history and of the research group where I work. And now we are going to talk about the methods. It means the way we do research in our group. Again, I think it could be interesting for you to compare a little bit how we work here. First of all, the research areas we have in our group research are basically these 9 points: early psychotic episodes, autism, affective disorders and suicide, psychotic disorders, childhood and adolescent disorders, prevention and early intervention in mental health, neuroimaging, cognition, and genetics. I marked the point number 1 and number 4 because they are the most in which I'm more involved. So I focus my work in psychosis. So I work almost in I work the most in early psychotic episodes and psychotic disorders. There you have like a little picture of how is organized our research group with the different areas of research. As you can see, the group leader is Celso Arango. I just introduced you before, and the research coordinator is Covadonga Martinez. It's like my immediate boss in the group. Here you have another picture of every project and trial and study and cohort that we have in every area of study of our research group. As you can see, there's a lot of study. We have several number of studies ongoing. This is my the research coordinator. Well, she's actually a brilliant researcher in Europe. The picture is she receiving a prize in recognition of her career as a researcher, and she coordinates a great group of, we are like 15 psychiatrists with mixed activity between research and clinics. More than 15 collaborators, more than 15 neuropsychologists, 2 specialists in genetics, 1 biologist, 2 specialists in neuroimaging, even 1 biological engineer, and 2 nurses and 2 data entry. So it's a huge group. This is my teammate. We are all psychiatrists and medical doctors. We are all PhD students. As you can see, every one of us is dedicated and focuses his work on a different topic. Could be genetics. We have a colleague focused on neuroimaging, and we told me we are more focused on psychopathology. This is how we work. Actually, this is a picture of a screenshot that I made yesterday of this week. As you can see, that for the dates is November 2024. So this is the calendar we have for doing of the evaluation of the participants, the different projects we have. So it's a little bit crazy. As you can see, there's a lot of studies ongoing, a lot of trials, and yeah, that's how we organize our work. So now I'm gonna talk a little bit about 1 cohort and 1 trial and 2 studies which are more involving, so I can speak better about them, and so you can make like a general picture of what kind of work we do in our group. Okay, so this is a cohort of it's called IISGM, and it's called like that because in Spanish it means ambientes y genes en esquizofrenia, that is like environment and genetics in schizophrenics, and CM it's just Comunidad de Madrid, the place where we live. This is a huge cohort of first episode psychosis, one of the largest one in Europe. And we recruit people between 7 and 40 years of age with less than 2 years of psychotic symptoms. Of course, they have to sign an informed consent. And we recruit also healthy controls, much for age, sex, and socioeconomic situation. So this is the recruitment progress of this cohort of first episode psychosis since February 2018 till a couple of months ago, till this year. So here on red, you can see the objective for 2026. On dark blue, you can see how the recruitment goes nowadays, and the other colors, it's like the recruitment progress. Okay, on the left you have the patients, means the people who had psychotic symptoms. In the middle you have the healthy controls match, and on the right you have the siblings. Okay, so brothers and sisters of the patients participants in this cohort. Okay, this is the scientific technical objectives of this cohort. So, wait, sorry, I've just lost my presentation. I'm sorry, I'm trying to go back to the PowerPoint. Can you still see the PowerPoint?
Yeah, we can still see the slide full screen version of it.
Okay, because I've lost it and I don't know how to continue like this. I'm trying to.
Well, you can close it and then open it again, I guess.
Okay.
You can close the PowerPoint
Yeah.
and restart it.
Mm. Okay. Okay, now, sorry for the inconveniences. Okay, now perfect, it works for me also. Okay.
Okay. Sorry, we can still see the full screen slide. HCM, scientific technical objectives.
Okay, so you can see it.
Yes.
Okay, perfect. So I continue, sorry. Okay, the objectives are this 7 the 7. The first objective of this first episode psychosis course is to analyze the environment and gen interactions, as I said before, in a sample of patients with first episode psychosis, and the degree relatives, and a paired sample of healthy controls, as I just said before. The objective number 2 is to apply genetic neuroimaging techniques to assess the association between common variants in candidate genes and genetic variants identified in genome with association studies on longitudinal structure and functional brain changes in patients with first episode psychotic episodes, first episode of psychosis. Study the longitudinal changes in the oxidative stress markers, inflammatory and other biomechanical markers in patients with first psychotic episode, and controls by means of the analysis of plasma markers and brain metabolites using magnetic resonance spectroscopy, and examine the influence of genetic and environmental factors and their interaction on the development, course, and prognosis of psychotic disorders. Examine the symptomatic dimensions affected in psychosis and its stability over time. To study the influence of genetics and environment, interactions on the evolution of cognitive and neuropsychological functioning in patients with first psychotic episode. And finally, to evaluate the efficacy of mindfulness-based group intervention to improve social cognition and social functioning in patients with a first episode of psychosis. Okay, so this is more or less the objectives and of this cohort of first episode psychosis. As I said, is one of the greatest in Europe. Okay. Okay, I cannot continue with the slides. Okay, so we do some clinical trials also in the group, even if it's not our main goal or our main activity, but sometimes we also do it. I'm going to talk about a randomized clinical trial, controlled trial that in which we participate. It's called Purpose. It's a placebo-controlled trial in subjects at ultra high risk for psychosis with omega-3 fatty acids in Europe. So, yeah, there's already a paper published last month about this trial, but I will talk a little bit of the results in the next point of the presentation. But yeah, just let you know that we also participate on clinical trials. Okay, in this case was a very easy one, was just to give a participant with had criteria for ultra high risk of psychosis for psychosis, giving her in that case some supplements of omega-3 fatty acids. And we also participate in some international collaboration, particularly myself. I'm involved in two of collaboration with United States. The first one it's called FEP Causal. FEP means First Episode Psychosis Causal Collaboration. It comes from Harvard University in the United States. Yeah, comes from group research that is called Causal Lab. That it's one of the United States National Institute of Mental Health advanced laboratories for accelerating the reach and impact of treatments for youth and adults with mental illness. This project is an international consortium of prospective cohorts of subjects with first episode psychosis. And the research includes clinical and sociodemographic data, including repeat measures of symptoms, severity, and psychological functioning on more than 2,500 subjects recovering from a psychotic episode across the globe. Okay. The goal of this project is to study interventions to guide treatment choices of clinicians and patients with first episode of psychosis. This is the second one. It comes also from the United States, but from Yale University. This is called PRONET. That means Psychosis Risk Outcomes Network. This is an project for people with ultra high risk for psychosis, ages between 12 and 30 years. And yeah, the recruitment papers said something like notice a recent change in your thinking, your behavior, or your experiences, such as confusion about what is real or imaginary, feeling that you are not in control of your own thoughts, feeling suspicious or paranoid, having experiences that may be not real, such as hearing sounds or seeing things that may be not here, and having trouble communicating clearly. And yeah, most of people who have these symptoms do not develop psychosis. But what we are trying to do with this project is to understand why some people who have these experiences do develop psychosis while many others do not. So yeah, this is a project focused on ultra high risk of psychosis. As I said before, it came from the university. The other one, proposal, came from Harvard, and our research group is more like a collaborator, okay, group with them. Okay, this is how Pronet works. We do a clinical interview. The clinical interview focuses on questions about daily life, friendship, studies, work, and about different experiences and symptoms. Clinical interview, it's what you saw before in the slide before, the Google Calendar with so many colors and stuff. Every color, it's actually a different project, and it's like the time we have with every patient to do these clinical interviews. Okay, so it is like our main daily work on the research group. We also take some biological assessment, and this include imaging by performing a brain MRI, scan and saliva, urine and blood test. And we do cognitive assessment. Well, actually, it's a psychologist who made that. And this assessment focuses on memory, attention, concentration, and learning. Okay, so let's go to results. Okay, after talking about a little bit about the way we do things in our research group in the last point. Now we are gonna talk a little bit about the results of all this research, of all this work, and collaboration with other groups and so on. So this is the number of publication of our group from 2016. Well, actually, for 2017 till 2022. This is more recent that I found. This is of this year. So as you can see, we have like 37 first decile publication, 72 first quartile publication, and 111 of total publication. This is the paper I was talking before about if you remember the clinical trial I talked before about the omega-3 fatty acids in ultra high risk population. Well, you have available and with open access a paper. It was just published, and as you can see on 25 of October 2024. So it was like a couple of weeks ago. Well, you can check it if you are interested. I can advance you that the results, the findings say that, we actually don't find that supplementation with omega-3 prevents the transition to psychosis, but yeah, I think it's interesting to check it anyway. But the results weren't significant. So this is the results of the results published in the first paper available from the FEV causal collaboration. Okay, this first scientific report using this data estimated the comparative effectiveness of different antipsychotic agents for initial choice as treatment for first episode psychosis, and successfully benchmarking estimates with the largest randomized clinical trial of antipsychotic initiation in first episode psychosis to date, and extending the results to new medication. I think this is a very interesting paper. I'm going to show you in the next slide. And the current ongoing projects aim to examine with this data to examine gender differences in clinical trajectories, treatments, and outcomes of first episode psychosis patients, the comparative effectiveness of different antipsychotic treatment in terms of psychosocial functioning, the potential role of olanzapine use for treatment-resistant first episode psychosis patient, and different strategies of discontinuation for patients who has arrived to a sustained clinical recovery. So this is like the next objectives with this data. This is the paper that is already available. It's published in the American Journal of Epidemiology. It was this year, like in April. Yes, exactly. I think it's quite interesting. So you can check it if you are interested. And yeah, with ProNet, we have several papers published recently, but this was the first one in which we present a little bit the design of the study. So again, if you're interested, you can just check this paper to know a little bit about this project. Okay, with these examples, I want to show that all the work, all the collaboration we made with Harvard, with Yale, with one and another has some results that are available in the literature. Okay, so we just arrived to the discussion. As I said at the beginning, this part I'm going to focus on my personal work on research. So this is the one of the ideas. Well, the first idea I came with. If you remember, I presented my project to the Ministry of Clinical Predictors in first episode psychosis, and the first predictor I started to analyze was neurological symptoms. Okay, so I focused my first part of the work in extrapyramidal symptoms as an early clinical predictor in first episode psychosis. During this last year, I made some communication. I made a paper, but it's not yet published. Hopefully, next year, probably at the beginning of next year, it will be published. I hope so. But well, I made some communication about this topic in the ECP Congress as a poster in 2023. Spanish National Congress of Psychiatry in 2023 as an oral communication, and this year in Palma in Mallorca was the Congress of the World Association of Dual Disorders, and I made I exposed to some findings related to substance use and extrapyramidal symptoms in first episode psychosis. This is the poster of the ECNP. This is now I got some more interesting findings, but as they are not yet published, I just show you the ones who has already put in communication in Congress. Well, what I've done with this sample is, well, it's taking a sample of a large sample, European sample of first episode psychosis, and we studied the prevalence of extrapyramidal symptoms in naive patients. So not just as a side effects of antipsychotic drugs, but as a primary symptoms of psychosis. Okay, and if you read some of classical nosology or psychopathology, I'm talking about Kraepelin or Bloiler, you can already notice that they have description about motor signs in patients, and this is long before the use of antipsychotics. So motor symptoms and neurological symptoms, extrapyramidal symptoms, are not just side effects, but also can be primary symptoms of psychosis. So what I made is to divide a sample of first episode psychosis, naive, in two groups. The one who has neurological troubles, neurological things, extrapyramidal symptoms, and another one with another group with no symptoms. And we have studied the evolution with several clinical and functional outcomes. during 4 weeks, during a month. And we found that the one who has baseline extrapyramidal symptoms at follow-up has these outcomes. PSP means personal and social performance, which study the functionality of the patient. The next is subjective well-being. As you can see, this person has worst and poorer functionality and poorer subjective well-being. Well, CDSS, as you well know, is a Calgary scale that rates for depression, and the PANS, the general and total PANS. And you can see that the one who has extrapyramidal symptoms at baseline, at follow-up, get worst depressive symptoms and worse psychopathological symptoms, general and total. So, conclusion: people who has neurological symptoms at the beginning of the disease, in the first episode psychosis, even naive to antipsychotic treatments, develop worse outcomes, worse functionality, worse subjective well-being, more depressive symptoms, and greater general and total psychopathology. So these are the major findings of my work at this moment, and yeah, I'm waiting to have them published in a scientific paper, hopefully soon. This is an extra additional analysis we've made with suicidality, and here you can clearly see that the one who has no EPS has a lower portion of suicidality compared with the one who has EPS at baseline and on follow-up. And you can see that at follow-up, after the beginning of the treatment, this suicidality goes a little lower, but the gap between the EPS group and the no EPS group comes a little higher. So, okay, and I'm finishing this little presentation. I would like to talk a little bit about volunteering. I do volunteering. This is a thing that Aliona, your colleague, finds interesting. When I talked to her about it, she was always curious about this. So to end this presentation, I find interesting to talk to you a little bit about this. I work with a ONG that it's called a Recover Foundation, Hospitals for Africa. I made 3 missions in Cameroon from 2022 till this last summer. We have a project that is called Trainer of Trainers. The objective is basically have some, this is me there. Patient care. We do virtual patient care here. I do it well every time I find some free time. I collaborate with them with virtual patient care. In this mission, we do on-site patient care. We try to visit as much as hospitals we can in every mission, more or less like 3 hospitals per mission. And yeah, the objective is training local health workers there into psychopathology, psychopharmacology, and anti-stigma also, and also into research to help them to develop a better mental health care, because there in the country there are I think there are 5 psychiatrists in the whole country, and there are nurses actually who take care of mental health patients. So they don't have a good trainee in psychiatry. So yeah, like our mission there is not just taking care of patients, because then we have to come back and let them there, but do some training to these nurses, the people who actually take care of them, of the patient there. And yeah, I think it's an important thing of my job apart from the hospital and from research, and I'm very proud of it. And yeah, as Aliona was interested, but I thought you were interested. Oh, and yeah, I'm finishing. This is the last slide with some conclusion of this presentation. I hope you have enjoyed. I really enjoyed preparing it. So hopefully you too listen to me during this time. And yeah, the conclusion is I think it's very important to have a previous clinical training and experience to work in research. Yeah, I think it's important to have current full-time research work if you are available. I know that not everyone and not every place is able to do that, but yeah, I think it's important to have at least enough time to do a good time in research. Of course, it's essential to have a good clinical trainee to get together the two parts, clinical and research, because of the importance of translational research. And I think it's interesting working in a large research team. And if it's not possible, again, one of the priorities to get some network connection, as maybe we are doing right now. So I keep in touch with Aliona, and hopefully maybe we can do something together, you in Russia and us, and yeah, and we here in Spain. So I think that's very important to establish some networks between different places. It's more or less what I'm trying to do in Cameroon also, to to help develop science in every place. And yeah, it's next point, it's the same thing, collaboration with international projects. It doesn't really matter if it comes from United States or from Africa, from Russia. I think the most important thing is to get in touch, everyone. And yeah, well, I focus my research on psychosis and predictors of disease. I think, of course, it's important to communicate the results we have in order to help develop the science. And to me, volunteering is important too, not just for helping develop the science, but also humanity in general. And yeah, for your information, I left some links here. If you want to check some of the projects I've talked during this presentation, it's open. Yeah, thank you very much for having me here, for your time. I'm very glad to be here with you, and yeah, спасибо.
Okay, thank you, Dr. Galvan. First of all, I want to thank you for the tremendous job you did. I know how hard it is to talk in foreign language for an audience for an hour, and thank you. Well, I personally appreciate the art. I appreciate Velasquez. I appreciate Kandinsky and our other avant-garde artists you used for this presentation. So, okay, dear colleagues, if you have some questions, you can write them in the chat, or you can use the palm sign if you need some help with translating it from Russian to English. I'm always ready to help. So, okay. So everybody is a little bit shy. That's okay. Well, I have a couple of questions. Valeria, yeah, go on.
Oh, no, you go ahead first, and then I'll ask my questions.
Okay. Then my first question is about the work on the association between EPS and suicidality. By suicidality, you mean rate of suicide attempts or suicide deaths or suicidal thoughts or what?
By suicidality, we talk about risk of committing suicide. Okay, it's like a complex between ideas of it's like a continuum. Okay, we made it like a dichotomous variable. Okay, like a yes or no. So it was an item. I think it's the eighth item from the Calgary who with
Okay, yeah. I get it.
about
Yeah.
suicide. So we just dichotomize this variable, and yeah, we made yes or no, and it was like a complementary analyze apart from the Calgary to try. Well, we found that there's a lot some papers who have done it. I know it's not the the ideal way to evaluate suicide, but yeah, it was like the only option we had to look into that, and it's actually a complementary analysis in the paper I'm preparing, but the results were like very very big, the very big effect and very significant. So we found it interesting because in the discussion of the paper, well, I suggest that maybe this kind of symptoms of neurological symptoms could be like a suicide risk item, like an early suicide risk item because of the findings.
Yeah, thank you. That's a very interesting notion. First, it's not ideal, and nothing is ideal, but it's kind of legit measurement of suicidality. And well, I personally write my PhD thesis about suicidality in schizophrenia patients and affective disorder patients. So I was going to ask about this. Since Valeria was so kind to give me some time to express myself, in the beginning of your presentation, you asked about how the training process is in Russia. Well, we have a little bit more simple system. We have just 6 years of medical school and 2 years of residency.
Okay.
We don't have the national competitive examination, but well, it's just simpler. Yeah, and maybe it's kind of a personal question or not, I don't know. You said that you will, right now you're a full-time researcher, so you don't have any clinical practice.
I actually nowadays I do some private clinical practice, and
Okay.
but also I'm on call. I'm on
Yeah.
call. Yeah, during the hospital, like 3 or 4 times per month. I'm on call on the hospital, so I keep in touch with clinics in a private clinic, and well, in my private consultation, and also on call on the hospital. And yeah, my idea is to back to clinic, or back to a mixed activity clinic and research after I get the PhD. That it's like my main goal right now.
Yeah, cool. Thank you. Because, my question was about this balance between clinical activity and research activity. And as a practitioner myself and a researcher myself, I find it sometimes, well, a little bit difficult to maintain this balance.
Sure.
Especially, I don't know how in Spain, but in Russia, research work is, well, not maybe underpaid, but clinical practice brings more money, and everybody wants to eat something. And if some doctors, they just want to do research, they don't want to do clinical practice, but some of us, well, we have to, because we have to have some money. Okay, Valeria,
Well,
please.
it's the same here. It's very hard to get that balance. I've done it before during 2 years, and as I find it so hard, I just decided to ask for this grant to the ministry to focus full time on research, just to get the PhD. And yeah, as I said before, probably after that, I will back to clinics and try to get again that difficult balance between clinics and research. But it's more or less the same with this grant. As I said before, I'm I'm making much less money than with clinical practice, so I have to refuse to money to dedicate myself full time to research. But it's like, it's a decision of today that I think will bring me more opportunities tomorrow. Maybe I'm wrong, but well, but it's
Okay.
more or less the same here.
Yeah, thank you, Dr. Galvan. For the audience, it's not just my interest. Well, as a part of the early career psychiatrist section of our psychiatrist community, I'm interested in these, you know, questions of about us, a psychiatrist about psychiatrists, how we work, how differs our work between countries, between different regions in Russia. Well, me and Ilona, we were in Uzbekistan, Samarkand, early career psychiatry school this spring, and we made some kind of a roundtable discussion with our Uzbekistan colleagues, and we discussed these topics. And next year in Suzdal Medical School, we're planning to do this open table again, and we invite you all to the Suzdal Early Career Psychiatrist School, and where we discuss this and a lot of other questions. So thank you for your time. Yeah, I guess now we can let Valeria speak. Thank you for your kindness, Valeria.
I want to say thank you for your presentation, because it's really nice hearing from people from just different countries on their research and how they collaborate with their colleagues from just all over the world. So the first question I have is, do you evaluate the prodrome of your patients? So do you retrospectively look at what was going on prior to their first episode psychosis? Because you were talking about evaluating your patients based on their the first symptoms they present with within psychosis, and then the later evaluation. So do you evaluate their prodromal symptoms? Do you use any methods, retrospective methods, to do it?
Yeah. Well, actually, what we are trying to, it's a good question. I think all the concept of high risk for psychosis came from this question. I mean, to see what have people who had a first episode psychosis, what they have in common, and because of that, I think the concept of high risk for psychosis come from that. What we done now, what we are doing now, it's not just to take the first episode psychosis and do a retrospective work, but I think that's already done more or less. What we are doing now is try to identify people who had risk for psychosis, and for that we have there are like, well, at least I know three different scales. One it's called the CARMS, the other one is the SIPS, and the other one it's a new one that is made for this jail project that it's called the Psychs. Okay, and taken together, what they had in common is that we have like three groups of people at high risk for psychosis. The first one is the one who has first relative with a psychotic disorder. Okay, if your mother or your father or your sister or your brother has a psychotic disorder and you have a decreasing functionality in the last year, you are under a high risk for psychosis. So this is the first group. This is like we call the vulnerability group. Okay. The other group is the one who has some blips, that it's like brief psychotic symptoms, you know, or psychotic experience. We all know that like 25% of population could have some psychotic experiences. So if you have some short psychotic experience, then we evaluate you to see if you are actually under a risk for psychosis. It's very common in we have on this kind of projects at ultra high risk of psychosis. We have a lot of teenagers that have a personality closer to a borderline, you know, because they have a lot of psychotic experience sometimes. So if we detect that, it's very common to see it in the emergency room when you're on call. We try to get this patient and to study and to maybe to offer some kind of project to see how longitudinally it goes. Okay, but we focus on the Of course, we try to study the history, the family history, and so on. So, and the other group that is probably the most common that we have, it's what we call attenuated psychosis. It's like you can you have a good functionality, so you are not unable to do your everyday things, but you have some kind of experiences that are not just you're not hearing a voice talking to you, but maybe sometimes when you are very stressed, you can hear a voice like calling your name, or you have the feeling when you're on the street that everyone is watching at you, or maybe spying you in some kind of, but you're not elaborating like a delusion, like like it's a FBI or whatever it's, but you have this kind of experiences. And what we do is to, well, we are made a lot of work from research to clinics to talk to clinics about this kind of symptoms, to detect them in consultation in the emergency room, and in the inpatients in the hospital is more difficult because there you have more first episode psychosis. They have already made the transition, but we have made a lot of work to try to from research to the clinics, trying to detect these symptoms, these signs. Okay, probably they are more signs more than symptoms, to detect these people who has risk for psychosis, and then to have more like a longitudinal follow-up more than a retrospective. Okay, so I don't know if I've answered your question, but we use methods to evaluate at this time the risk for psychosis, and then to have a follow-up more than, and I think this kind of skills come from the idea you just say, that to see in retrospective what they had in common, to see, to detect that they are under a high risk for psychosis.
Yeah, I was kind of thinking, oh, sorry, go ahead.
No, sorry. Go
Yeah,
ahead.
I was kind of thinking that perhaps you would evaluate people's prodromal symptoms to see how what their outcomes would look like based on their prodromal symptoms. So just not only the first psychosis episode and how it works and what what symptoms patients present, but also like their prodromal stages and the length of like untreated psychosis and things like that. So prior to their hospitalization. So some sort of retrospective evaluation.
We actually we do that. We also do that. But we use these scales for the prodromal symptoms. I don't know if you are familiar with them. If not, I can send them to you. These are these three. At least as far as I know, it's the CAMS, the SIPs, and the psychs, and they evaluate prodromal symptoms of people who are not who has not made the transition to psychosis, but they have, well, we suspect, we have the idea that maybe they are at risk of it.
All right, so this is a separate study, right?
Sorry?
This is a separate study, right? So you were kind of talking about just different studies. You were talking about a study on high risk and ultra high risk, and you were talking about your personal study for your PhD.
Yeah.
So the PhD study is only for patients with the first episode.
Yeah, exactly. There are different studies. My PhD studies is focusing people who has already the first episode psychosis. If your question was if I made some research in retrospective in the sample, the answer is no. Yeah. And we have a couple of more studies focused on ultra high risk on psychosis in where we do this kind of research with these scales I've been talking about, and we divided the sample in these three groups of high risk of for psychosis, but there are different samples and different studies. And yeah, well, as I show you before, we have several studies, and we try not to mix the samples, but sometimes it happens because sometimes even what happened to us very frequently is that some people who came to us as healthy controls, after some evaluation, we find that actually they have a risk for psychosis, and so they change from healthy controls to from study to participants to another one. And of course, if someone is in a ultra high risk for psychosis study, and he finally do the transition during the follow-up, he can get into the study of first episode psychosis. But there are different samples, and yeah, in every study we have our scales and our measures. So in my project about neurological symptoms and predictors of disease, it's a prospective follow-up, and we do the measures focusing on after the first episode psychosis.
Mhm. So do you use any scales for assessing motor symptoms, or it's just you creating your own scale?
No. We're using a scale that it's called the UKU. Okay, it's I don't know if you're familiar to them. It has not just neurological symptoms, but also dermatological symptoms and sexual symptoms. It's like was created like a side effect for antipsychotic scale. Okay, but we are using it at baseline patient. Okay, so naive patient, and we can see if they are they have this kind of symptoms before taking the drugs, before taking the antipsychotic. My next idea is to replicate these symptoms with dermatological symptoms. Okay, I've been working on psychodermatology for a couple, because I have a good friend of mine is a dermatologist in another city, and they invited me to do a speech like this some months ago, and I started to doing some research in psychodermatology, and I find in the same sample with this scale, the UKU, that it could be we can have a significant association with outcomes of follow-up and dermatological symptoms at baseline. But okay, it's like it's more like idea project to have the second step to follow the neurological symptoms, and yeah.
Yeah, that's an interesting thought, because I've never heard of anyone talking about dermatological symptoms and the outcomes. So it would be interesting to see the results.
Yeah, I think it could be novel for psychiatry. In fact, I think it's not so crazy to think about it, because if you remember embryology,
Mhm.
the brain and the skin come from the same from the same I don't know the term in English, but from the same thing when we are
It's the layer from the same layer of embryo,
yeah,
ectoderm.
the ectoderm, exactly.
Yeah.
So yeah, and because of all the there's a lot of research in inflammatory cells and stuff like that, and well, dermatologists, they just use corticoids because all is related to inflammation and stuff like that. And there's a lot of research in psychiatry about inflammatory blood cells and psychosis and stuff like that. So I think it could be related in some way. And hopefully, if I finish successfully with neurological symptoms, I maybe I will focus on dermatological symptoms. But we'll see. It's just like an idea, an embryological idea.
That's a good one. Good luck.
Thank you.
Okay, thank you. Do anyone have any more questions? Well, I personally admire the well-structured, how well-structured your research workflow in your country is, with this network of collaborative research projects. I hope one day Russia will be the equal partner in these collaborations. And well, that's cool. Because I don't know about the colleagues, but in my research practice, there is a teeny tiny element of chaos almost every day. And there is not so structured. And also, I noticed a funny coincidence. You showed us the paper, which first authors was Alejandro Shmulevich, I guess. And the funny thing is, back in Russia, we have a living classic of Soviet and Russian psychiatry. His name is Anatoly Smulevich. He had the same surname, and he also had works in Adolescent and psychosis, on schizotypal disorders in youth, and well, maybe that's hereditary. I don't know.
Yeah, well,
Okay.
I think he's from Argentina, and I think he's actually he's not a psychiatrist. He's like an epidemiologist, and he's an Argentinian epidemiologist. He works in Harvard University in Boston. But yeah, it's like a nice coincidence, maybe.
Yeah. Okay. So if we discuss anything, Dr. Galvan, maybe you have some questions to us. It's a rare opportunity to, I don't know, discuss our inner kitchen,
Well, I've talked well a little with Aliona during her stage here with us, and well, she explained me a little bit about the work she does there, and yeah, how you work there. I will be happy to keep in touch with you, or maybe do some common future projects on research. Yeah, yeah. Hopefully, maybe I can do a little stage there. Maybe in another time or in another moment. We'll see. Yeah. That's all. I actually I'm in touch with Aliona, and I talked to her, but I'm very glad to be here. Yeah, I don't know what ask you now. Maybe
Yeah, I
another
get it.
time. A lot of questions came to me, and maybe I ask her, but I will be really glad to keep in touch with you, with all the group, and I don't know. I'm available for you for whatever you need, or whatever ideas you will have to to share with me or with us. Yeah, I would love to meet you in person sometime, there or here. I think I don't know if you're uh, familiar to the EPA Congress, the European Congress. It will be in Madrid next time, so it will be great if one of you can come and maybe discuss in person. Because
Yeah.
I really love to meet colleagues from from all around the world, to see how we work in every country. And yeah, maybe we can keep in touch. I can ask for your contact to Aliona, and we can keep in touch.
Yeah, sure. Vice versa. It would be my pleasure, and all of our colleagues' pleasure, I guess. Thank you for
You're welcome.
this. Thank you for this wonderful evening, for you with us, for your presentation. And I guess if we've discussed everything for it,
Mhm.
so we can round up.
Okay.
Thank you, Dr. Galvan. Thank you for spasiba. Muchas gracias, Dr. Galvan. Buenas noches. Yeah, sorry for Spanish. It's awful, maybe, I guess.
Oh, it's good. It's good. Your pronunciation is very good. It's actually good. Congratulations.
Okay, thank you very much. Thank you very much. It was our pleasure. Thank you.
My
Goodbye.
pleasure. My pleasure. Take care. Bye bye.